Good afternoon, everyone. Welcome to the Washington College of Law. Thank you for all of those who are joining us here in person, and thank you to everyone who is joining us online. My name is Maya Manian. I am the Faculty Director of the Health Law and Policy Program and Professor of Law here at WCL. On behalf of myself, our Director Asha Shelzo, and the Health Law and Policy Brief, we welcome you to this event on the social determinants of health and health equity, where we live, what we eat, and how we access it. Our expert panelists today will be talking about the environmental factors, housing conditions, and dietary constraints that exacerbate more traditional concerns related to healthcare access and quality. Today's panel will also examine the systemic inequities entrenched in health, housing, and food, and explore how medical legal partnerships can be leveraged to improve health equity. I want to thank our distinguished panelists today for taking the time to address these important questions about health equity. And I also want to especially thank the organizers of this event, Hallie Hoffman, Devin Malouf, and all the editors of the Health Law and Policy Brief. I also want to thank our wonderful staff here at the Washington College of Law, without whom we could not host these conversations, including our special events department, our catering department for the delicious food that sustains us, our audiovisual team, and facilities department for helping to set up this event. So before we launch into our panel discussions, it is my great pleasure to introduce the moderator of our first panel, Professor Thomas Williams. Professor Williams is Assistant Professor of Law here at Washington College of Law. Prior to joining WCL, Professor Williams worked at the Duke University Initiative for Science and Society, where he was a lecturing fellow, and where he was also a postdoctoral fellow in the Law and Biosciences Department and director of the Duke Engage Washington program. His work focuses on the integrative analysis of health law, bioethics, and entrepreneurship. And his recent scholarship considers the role entrepreneurs can play in the mitigation of health inequities and disparities. So welcome everyone, and thank you so much, Professor Williams and our panelists.
Thank you, Professor Manian, for that very generous introduction. Thank you, panelists, for being here today, and a huge thanks to the Health Law Brief for making the space for this to happen. And I would love to echo Professor Manian's thanks to the staff, right? None of this happens without staff. I'm first going to introduce our panelists and then set the tone or create some space for a shared definition of social determinants of health. It gets tossed around so much in conversation. And so I want to give folks just a little bit of history as well as a working definition. Always feel free to push back. That is what scholarly engagement looks like and should represent. So Professor Emily Benfer at the end is director of the Health Equity Policy and Advocacy Clinic, which is a medical legal partnership, and an associate professor of clinical law at the George Washington University Law School. She's also a visiting research collaborator at the Eviction Lab at Princeton University. From 2021 to 2022, she served as a senior policy advisor to the White House on the American Rescue Plan implementation team. She is the chair in absentia of the American Bar Association Task Force on Eviction, Housing Stability, and Equity. If that is not enough, during the height of the COVID-19 pandemic, she conducted nationwide research and policy surveillance on U.S. housing policy and health equity, and was the co-creator of the COVID-19 Housing Policy Scorecard with the Eviction Lab. Her area of clinic practice and research includes health equity, social justice, housing and eviction, interprofessional education, environmental and racial justice, and medical legal partnership. Online with us via Zoom, Professor Andrea Freeman. Her work and research sits at the intersection of critical race theory, food policy, health, and consumer credit. She is a pioneering theorist on food oppression, which examines how facially neutral food-related law and policy, influenced by corporate interest, disproportionately harms marginalized communities. She is the author of Skimmed: Breastfeeding, Race, and Injustice, and her new book coming out this summer, Ruin Their Crops on the Ground, which traces the use of food as a tool of subordination. She is the recipient of the 2020-2021 Fulbright King's College London U.S. Scholar Award to study food equality in the United Kingdom. Previously, she was a professor at the University of Hawaii School of Law, and last year she joined the faculty of Southwestern Law School in Los Angeles. Finally, we have Professor Bunmi Ogungbe. She is an assistant professor at Johns Hopkins University, where she is a nurse and cardiovascular epidemiologist, and she dedicates her work to advancing health equity through research and community-engaged intervention. She's an emerging leader in community-engaged research advancing cardiovascular health equity, both locally in the US and globally. Her work encompasses assessing the impact of individual level and structural social determinants of health through use of spatial methods, implementation of tailored cardiometabolic interventions, and the characterization of cardiac post-acute sequelae, which my former 1L contracts students, I will tell, I looked up because I thought I knew what it meant, but I wanted to be clear, which references the consequences of previous disease or injury of COVID-19. And implementing novel methods to improve diversity in biomedical research. Her global cardiovascular health work focuses on advancing team-based hypertension and novel hypertension medication and adherence approaches, among others. So again, thank you all for being here today. I'm excited about this conversation and the convergence of the things that you think about and work around the opportunities and challenges that it presents moving forward. So before I launch into a couple of questions that let you guys explore the background that is necessary for this, I'm going to just talk for a couple of minutes about the concept of social determinants and the history of social determinants. I want to ensure that we're working from the same playbook regarding terminology. Lots of folks are familiar with the idea of social determinants, but I want to provide something a little more concrete, especially those who are pulling the definition from context rather than literature. And to also tell folks just a snippet about the origins of this thinking and the emergence of social determinants of health, because I think that provides important context as well. Again, panelists, please feel free to push back or to add richness to that description. So many of you may think that social determinants of health has its origins in the United States. It's a domestic concept. That would be incorrect. The first nods towards its scholarly and at least policy import in the West appear to have emerged in the late 1960s through the UK's Whitehall study, which attempted to pinpoint the origins of downstream health implications providers continued to see over time. Its findings correlated many of those downstream impacts to employment and, in the British context, hence socioeconomic status. In the US, the origins of the policy discussion we have now around SDOH might be traced back to Margaret Heckler's work. She served as the Secretary of Health and Human Services during the Reagan administration, and she convened the Task Force on Black and Minority Health in 1985. That task force was responsible for investigating widening disparities of death and illness experienced by minority communities, paying special attention to Black communities in the United States. There's good reason to connect Heckler's work and the motivations for the task force back to the public outcry following the Tuskegee syphilis research study conducted by the US Public Health Service. I'll work with the organizers to provide links to some of the articles that I pulled this history from so that folks can read up to the extent that they are interested. In 1999, the book Social Determinants of Health was authored by Michael Marmot and Richard Wilkinson. They would go on to lead the World Health Organization's efforts in the area in the first decade of the 2000s. For definitional purposes, consider this. SDOH are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So I'm just going to say that one more time to ensure everyone understands where we are. SDOH are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. As we will talk about today, that creates a much larger umbrella through which to think about our own health and population health more generally. SDOH can also include allocation of green space in communities, levels of crime, heat indexes. There's a long list to consider when we talk about social determinants. Increasingly, we are seeing more of these factors raised in policy discourse, which finally, after all that time, brings me to my first question for the panelists. So, Professor Benford, you have a very deep well of knowledge with respect to the ways in which health is impacted by individuals' housing status, especially with respect to the impact eviction has on the health of individuals and families. The link between housing and health is getting greater play in media and politics. We see it more and more each day, including increased focus from state Medicaid plans. For those of you that get confused between Medicare and Medicaid, Medicaid is a joint state federal engagement. And so housing is getting more play within thinking about funding in Medicaid systems. Can you give the audience the data to understand the linkages that exist between housing and health and the implications for health justice movements?
Yeah, thank you. Thank you so much for that really thorough explanation, bringing everybody up to the same page around social determinants of health, and for the lovely introduction. It's really wonderful to be here. So my understanding of housing health, and I actually have some slides. I don't know if they're pulled up or not. Are they?
I think if you hit next, you'll
Yeah.
get there.
Okay. Let's see. Try this out. This is.
And if not, I will be your attaché.
These are the nightmares that I have. But I first became interested in housing and health inequity and the relationship between the two. No, not yet. Here in DC, as a law clerk, my first year after, or the first summer in law school, and I was working at the Washington Legal Clinic for the Homeless. And I was representing children and families, and I was going from shelter to shelter in the district. And every single family that I met suffered from severe negative health outcomes. And almost all of them were connected to social determinants of health, that these were not genetic, that these were things that they had been exposed to. And much of it was stemming from their time in shelter, but also remnants of their time in substandard housing, the process of going through an eviction, the retaliation that they faced for reporting lead hazards or mold in their units. And all of these just really sped up that downward spiral of health inequity. And there was nothing we could do because we were so downstream, that the social supports were not available to bring people back up to a baseline that could even support health. And so that really, I think, drove the rest of my career, and focusing on medical legal partnership, moving upstream, but also always remembering those families and those individuals when I was thinking about, well, where am I curious? What do I want to know more about? And
It is ready.
Oh, good. Okay.
So I have just your title flag right now.
So I'm going to go a little deeper. Before I get into eviction, I think it's important to understand that housing is a pillar of stability. And when you wipe it out, everything else tumbles. It just knocks the rest of them down with it. And so housing ends up becoming a pillar, a pathway to health in at least 4 ways: affordability, quality and safety, neighborhood, and stability and access. So I want to talk a little bit about each one of these and give you some statistics about, what is that?
Oh, sorry.
speak
The
up.
folks online are having some trouble hearing.
Close Nick for right guys? We do this together.
Yeah.
So how does this, let's touch base on affordability first. So America's affordable housing crisis. So leading into the COVID-19 pandemic, can you see that? Yeah, okay. 20.8 million people were rent burdened. This is before COVID-19. Rent burden means paying more than 30% of your income toward your rent. Now, exiting the pandemic, so today, 21.6 million households are rent burdened. So we didn't stabilize during the pandemic. We actually decreased the amount of affordability of housing. Couple that with only 1 in 4 eligible renters actually receive financial assistance, and the loss of 4 million affordable housing units between 2010 and 2020. Today, we have a deficit of 7.3 million affordable units for extremely low-income households and 1.5 million units generally. Now, if you look at people who are under the poverty line, 70% of them are paying more than 50% of their income toward the rent. And half of that is paying over 70% of their income toward the rent. So what this leads to is we're one paycheck away from losing access to housing altogether. So what does this look like in DC? Well, in DC, 30% of renter households are extremely low income. We have a deficit of over 27,000 affordable units for the lowest income people who need them. And on a single night in DC, 3,400 individuals are homeless, and over 1,000 adults and children are homeless. And these are just the people who are counted on the street or in homeless shelters. It does not include people who are doubled up or couch surfing. So then who's this affect? All right, good. We're on track here. I had printed out my notes. I was so prepared and I left them on my desk. So I'm sorry for the barrier I've created here. I just want to make sure I'm on the same page you are. So who is this affecting in DC? Well, health equity is really deeply connected with racial equity. And in DC, housing disparities are mostly affecting people who are low income. So wards 7 and 8, you can see that the lighter the color, the lower the income. So the lightest blue is under $40,000 for a family of 4. And the majority of people living in wards 7 and 8 are upwards of 90% are Black. So this is a racial equity issue at the same time. All right, let's take a look at.
Just remember, can I
Yeah.
ask you one question?
Yeah.
Could you, if you remember offhand, just tell the students what the federal poverty line is
Today, I think we have 44,000.
for a family of 4?
For a family of 4, yeah. So this is below the poverty line in wards 7 and 8. So that's the affordability piece, but what about conditions? So housing conditions are obviously a pathway to health. All of these that I have listed up, they're mold infestations, unsafe water, unsafe heating, inefficient electricity, so people are forced to use their ovens to heat a room. They all create hazards to health. Now, in one of the first cases that we had is this picture, a client in Chicago in our medical legal partnership. Mrs. B, I'll call her, her walls would sweat when she would cook or when they would take a shower. The whole unit would just start sweating. And then pretty soon after they moved in, she started to see this like black artwork almost stretch across. It's like somebody graffitied the walls with black, but it was furry and moldy. It's like taking a fuzzy marker or something. And it started to stretch across the entire kitchen and into the bedrooms and on the ceiling, and it was in between the wall where her son's crib was. And she didn't know what to do, especially as her son developed this extremely deep cough. And he was suffering from an asthmatic allergic reaction as well as asthmatic distress. And when she reported it to the landlord, he blamed them for being dirty and threatened to have them deported. So feeling she had no other alternative, she and her family left and they started couch surfing, and that led to other health outcomes for them. So this is not an uncommon situation, especially in low-income settings where there's the risk of retaliation because our laws are under-enforced. Now, what does this look like in DC? The asthma rate in DC is the highest in wards 7 and 8. And the asthma ED visit rate for children or minors is the highest also in ward 7. Asthma is the leading cause of school and work absences. And I have a little more time.
I'll give you another minute.
Okay, I'm gonna speed ahead then. All right, so then very quickly, we have lead hazards as well. I think a lot of people are familiar with lead because of flint. But it's the largest source of lead is paint and the dust that it creates. There's 23 million homes that contain lead hazards and that are active, and 38 million that could become active. Lead poisoning is severely devastating. It causes permanent brain damage, neurological harm. African-American children are 3 times as likely and Hispanic children 2 times as likely to be affected. It leads to a whole host of negative health outcomes that are permanent. And over 6,000 studies, the American Academy of Pediatrics and Disease Control have all held that there's no safe amount of exposure to lead. And yet that's what's happening in these lower income units. And it's no different. You can see here where the lead is, again, largely concentrated where the lowest income households are. And federally assisted housing is no exception. In federally assisted housing, on the right, you see where the housing choice voucher is located. On the left is the presence of lead poisoning in Chicago. This is not a primary prevention approach, so people have to develop lead poisoning across the country in both private and federal market before any interventions occur. All right, so to finally answer, well, let me do one more.
Okay.
So neighborhood, I did want to talk on neighborhoods. So this is both the built environment as well as the environmental justice issues that you might face. And as public health practitioners have known for decades, one's health and life expectancy are determined more by zip code than genetic code. So what does that mean for stability? Well, over 69.7 evictions are filed between 2000 and 2018. 7.6 million people face eviction annually. Now, there are extreme racial and gender disparities in eviction. Overwhelmingly, we evict Black women. 22.4% of Black renters compared to 4.2% of white renters face an eviction filing. And among Black women, it's 1 in 5 versus 1 in 15 white women. Who do we evict in the United States? Children. Overwhelmingly, we are evicting children, particularly Black children. You can see 32.9% of the population threatened with eviction is below the age of 18. And 11% of all children under 5 face eviction each year, but that rate is 27% for Black children. So the people that we are evicting across the country don't even have the ability to enter a lease, and yet they're going to have the consequences of that throughout their lifetime. Eviction is predominantly in wards 7 and 8 in DC, but this is the last one I'll show you.
Okay.
Last one, I promise. I have to get to the health link. Eviction is a structural determinant of health inequity. I don't expect you to be able to read this. This is backed up by about 200 studies linking eviction with physical health, mental health, effects to barriers to livelihood, to well-being, all of which are devastating. And most recently, the eviction lab, my colleagues demonstrated that during the pandemic, having an eviction filing led to a 2.6 times greater risk of death than the rest of the population, and generally 1.4 times higher mortality for renters who faced eviction than they don't. So literally, eviction is killing them.
Thank you, Professor Benford. I was about to come after you, but thank you very much. No, this is great because it sets the ground for conversations about food, about all these other pieces that connect. And I'll just highlight that having housing doesn't mean having good housing, right? This concept of being underhoused, right?
Well, and I would challenge you on that because I think it's our definition of housing.
Excellent. Okay.
So housing should mean good housing
Okay.
as opposed to what I just showed you.
So you guys have policy work to do. We're staying here, right? Yeah, I'm serious.
The main point is that, so your definition of social determinants of health, so the World Health Organization has a conceptual framework where in the last 10 years, where they divide the social determinants of health into structural and intermediary. And the structural determinants include our laws, our policies, our budgets,
Excellent.
our enforcement mechanisms, and all of those are influenced by subordination, discrimination, bias. And so everything that I just showed you, there is either a law that is not enforced, or there are so many gaps in the laws that landlords are able to take advantage of that. And
I'm going to pause you.
use that system.
I'm going to pause you.
Yeah.
And we're going to move to Professor Freeman, but bring us back to the things that you didn't get to as we do the group conversation. Professor Freeman, thank you for being patient. Thank you for joining us. Your work deals with another element of daily life that I think a lot of us in this room don't think about as an inherently linked to health, which is access to food. Your scholarship links concepts of food oppression to the larger construction and definition of health. Can you walk us through some of the obvious and non-obvious ways that food systems and access are implicated in social determinants of health?
Sure, thanks for that wonderful introduction. And I just want to also say thank you. First of all, can you hear me? Okay, perfect. Thanks to Gavin and Hallie, thanks to the students that organized this, and I'm so honored to be here with all of you. And I really love what Professor Benford was saying, every bit of it, but especially at the end, where she mentioned the idea of not just housing, but good housing, because I think that relates a lot to food as well, right? It's not just food, something to put in our stomachs, we need good food in order to avoid the bad health effects. So I think that's a nice way to segue into what I'm going to try to do, which is share a lot of slides in a short amount of time, You can't physically come after me, but I know that.
You don't know my powers, Professor Freeman.
No, maybe this Zoom thing was actually a good thing. I'll try to do this like as quickly as I can, but you can cut me off if you need to. So this is just showing how poor nutrition, smoking as the highest cause of avoidable death in the US. And in all of the conditions, the food-related conditions that lead to early death and all kinds of problems, there are racial disparities. So high blood pressure, diabetes, strokes, chronic diseases, heart disease, a ton of cancers, strokes, obesity, which leads to other things, and type 2 diabetes. So, as you mentioned, my new book, what it really goes into, in the first part is the history. So there, if you're interested and you want to take a look at it later, you can see a lot about how colonization and enslavement and the attempted assimilation and Americanization of people immigrating into the country was a primary site of food being used as a tool to oppress and subordinate that caused these racial disparities in health way back that have continued into the present. So during enslavement, there was a sort of theory passed around that enslavers should feed their enslaved workers just enough to be able to work, but not to revolt. And then they had doctors that came in and said, oh, well, these health problems, which were caused by malnutrition and other things, these are actually racial differences. So there's that myth supporting everything. During colonization, there was a policy to ruin the crops of indigenous peoples on the ground and just to try to destroy their traditional food ways so that they wouldn't be able to eat and they would move and do whatever the US government wanted them to do. So this is just showing some of the massacre of the buffalo or bison, the trail of tears across the US, all of this motivated by starvation, the greatest mass execution in US history, which was in the Dakota War, started by the withholding of rations. So the US, while destroying these foods, would offer rations to replace them. And the rations eventually evolved into what we have a USDA food nutrition program today. So during the Depression, we saw the beginning of the subsidies of agricultural industries. So part of this was to try to feed people who were hungry, but most of it was to support the agricultural industry. And the breakdown that you see here from 2014 of who got what money started back then. And so what we've seen is through the consolidation of the agricultural industry, they have been able to control these subsidies and make sure that they continue to get them instead of them going to healthier foods like fruits, vegetables, beans, and that kind of thing. So what happened is a program that started to solve hunger ended up being one that created other serious nutritional problems that lead to early death that I started out with. So this is just a quick overview of the food distribution program on Indian reservations. It's full of the surplus of subsidized commodities, and it has led to extreme levels of diabetes on reservations where it's distributed. This is a kind of humorous, but not funny, mod bod, which is the result of eating commodity foods from the government, commodity cheese, that's fry bread. Okay, and then I want to jump into school lunches because school lunch.
Professor Freeman, you have 1 minute. I know it's hard. Okay.
So fast.
Okay.
All right, let's do it. All right. So school lunch, here's what they look like. They're subsidized commodities. Here's another beautiful picture. This is from Buffalo. People go online, they complain about it. Started in the thirties, then school lunches put on hold because the food got sent over to the military. But then they realized that people were they were malnutrition from joining the army. So out of national security, they formed a national school lunch program. So it soon became automated and schools were overwhelmed. And because of partnerships between the government and the big food corporations, these corporations entered into the food lunch scene. So now we have things like Domino's, Smart Slices. We have the support of pizza. Congress declaring it a vegetable. We have the walking taco. We have the complete inundation of public schools by the fast food companies. So they're all over, not just in the cafeterias.
Children's hospitals.
Support. We have Trump, your past and perhaps future presidents who will serve this instead of delicious food at banquets. And then, of course, we have, in the environments around a lot of public schools, these food swamps. And in my last 10 seconds.
I have a big sign that says time.
Yeah. Okay, but I can't. So we'll, there we go.
Okay, thank you. Thank you so much. I'm sorry we don't have more time. This would be 2 hours if it was up to me, but above my pay grade. Well, thank you, right? Because that speaks to, again, the structural elements, right? The definitions of pizza as a vegetable, but also the inundation, right? So at CHOP, when I was in Philadelphia, there was a huge fight about the McDonald's in CHOP, which is the Children's Hospital of Philadelphia.
Sorry, we're.
So that's not me. Okay. So Professor Lumbe, you come to this panel with a really unique perspective, and lawyers love to get together. We need some other people in the room. So you live and work in these clinical realities. You encounter the kinds of structural outcomes, right, that Whitehall studies started to think about. Can you give us a sense of the ways that the conversation right now is lacking when we fail to focus on empowering communities as we talk about housing and food amidst, right, a long list of social determinants?
Thank you. Well, first of all, thank you. This is such a wonderful panel, and I'm happy to be here. And thank you for the background information. That was really good. I'm just sitting here like this has just made my work really easy. You referenced the WHO framework. I have that on my slide. I pulled it out at the last minute. So that was really, thank you for where we are in this conversation. I do want to start with where this started to become really important to me. I remember being in class, I was getting my MPH, which is the Master's of Public Health degree. And my background, like he introduced, is in cardiovascular epidemiology. So I was learning about diseases, prevalence of disease, how many people have hypertension in Washington, D.C., for instance. That's the kind of thing I was learning about. And almost every lecture, we would have people come in and say, here is the overall prevalence. Some groups have it a little worse than others. And that's it. There was rarely, very, very, very rarely would a professor, a lecturer really go into, but these are the reasons. So very quickly for me and a lot of my colleagues, we started to question that. Actually, sometimes the language would lead you to believe it was genetic, similar to what the, Professor Freeman was saying. Almost like there's something, permit me to say this, wrong with those groups of people, and that's why they're having worse health outcomes. And this is what really led me to health disparities. And please ignore the title of this. This was done really quickly. Just like this is, but it's actually relevant because towards the end of the slides, I really I start to talk about work that we do with communities, how we partner with communities to ensure that we are addressing social determinants of health that can be addressed at that level. But even with policy, with a lot of people in the room who are really working on crafting some of these policies, thinking about those laws that keep people in the space where they continue to have and experience adverse social determinants of health. And very quickly, this is quite theoretical. I'll try not to lecture, but really helping us to understand how the link between health disparities and health equity how that works. What does it mean? the key word here for health disparities is prevention. This disparities, this system or this reality where we have members of the society having worse health outcomes due to a lot of the social determinants of health, housing that we started to talk about, food access. Those things are preventable. And how can we move towards equity where every person has opportunity, that important opportunity to achieve their full health potential? We can have, sometimes people argue that, we can talk a lot about making everything equal. We can talk about justice, ensuring that we remove the barriers. But at the very least, I think every member of the society should have access, not just access to quality healthcare, but should just by definition be able to reach the full potential of well-being that they can get to. So in the pursuit of health equity, what should we consider? Here is again another definition, but really moving from equality, which I think some of us may remember, it used to be equality, we want equality, but there's actually a difference between equality and health and equity. And actually there's an updated version of this image, some of us may be familiar with it, moving towards justice. So it's not just leveling the playground, as some people like to say, but it's even more removing the barriers. How we remove the food access barriers? How do we remove the rent boarding barriers? How do we ensure that people are starting with something? People are not at disadvantage relative to other members of the society. I will try to talk through this, but these are a set of graphs that, as Professor Banford, sorry, in my word we use Dr. Willem, Professor Banford was sharing, and she was making references to word 8 and word 7. And to my mind, we could lay these graphs or these maps directly on some of the ones that you showed. And here, I'm like showing something really different. On the left, we've got high blood pressure, because I do cardiometabolic health, that readily comes to mind, and inactivity. Inactivity is, a behavioral thing, people could choose to be physically active or not. And you immediately see, so the darker shades are worse, and the really dark dots, red dots, wherever you see darker shades of blue and red dots, it means those people or people in that neighborhood are more likely to have high blood pressure in terms of the prevalence, and are also more likely to have worse metrics in terms of physical inactivity. And that's it right there. There's a stark difference. And then to the right, I think I started to think, when I'm putting this together, I started to think about rent and eviction and rent boarding. So that shows rent boarding. And I think the health outcome there is just general physical health, how people rate their physical health. And it's very similar. Like you see where people, or in neighborhoods or zip codes, census tract, where people are likely to experience adverse, higher rent boarding. A lot more people are experiencing or really reporting worse health outcomes. It's not just that. Professor Freeman also started to really show some of these graphs in terms of just cardiometabolic outcomes. What groups in the society as a whole, in our neighborhoods, what groups have it worse? There's a statistic we like to cite in my my little part of the work in research and public health practice and clinical practice, where people say, about half of the US adults have hypertension, as an example. That is true. But you know what is true? Some groups in the US have metrics or prevalences higher than about half. So there are some groups where 50-something% of that particular subgroup have hypertension. Now, what is driving that? One, and really to answer your question, and I know we're almost done. Yes, I know, I answered it. So really to answer your question, it's that as we started to really see this and think through this and talk about this, it's important to understand that this is happening at the individual level, but also at the community level. So social determinants of health is multi-level, and that's really what the WHO framework shows us. There's the individual level, there's the interpersonal level, community level. What's really happening in the community? There is the policy level, society level, intermediate practice as well. But we also are working to tailor our interventions to these different levels. These are the targets. What can we do with community partners? Who are the key partners in the community? Faith-based organizations, CBOs, community-based organizations. How can we work together with them to craft and to create, to co-create interventions that is a priority to them, but that also meets their needs, and very importantly, would improve their health. I may stop. I do have some other slides that may be of interest to people. I can probably provide them after this stuff, but I'll.
Wonderful. Thank you. Thank you. That, like, you are the best kind of difficult to control group. Thank you for all your comments. I hope that for students and for others in the room that the linkages are starting to make sense between community focused and centered responses and understanding and seeing needs. So we have about 10 minutes. So I'm going to ask you 2 questions at once in an effort to push us along. And you take or leave what you think is important. Feel free to highlight components of your work. So there is very much a battle for resources when we talk about policy interventions and engagement in health. So what strategies, what mechanisms do you think appropriately center the conversation around health with creation and furtherance of models that incorporate these elements of social determinants of health in your experience? So that I'll say that's part 1. And feel free to tell me about models you don't think work or that we know don't work. The second piece is I sadly for my health law students make them talk about corporate reality. I spend a lot of time on it because it's really how the system. How do we get payers on board? How do we get the folks with money to acknowledge the centrality and the connections between these questions? I'll start with you, Professor Benford. I may end up rushing you along, but it's with love. But I would love to hear your thoughts because I think this is where the rubber hits the road.
Yeah, absolutely. So I think we're starting to see some of the payers shift in response to like medical legal partnership, which you're going to hear about in a moment with the Health Justice Alliance. So really seeing the return on investment and the value of addressing the social determinants of health to stop that revolving door patient that has such high costs attached to it. More and more, all of these social determinants of health are being associated with cardiovascular disease, which is one of the highest hitting costs, especially for those who are underinsured. So really addressing these at the front end, making the case for that is starting to shift where they're putting their money. Locally, we're seeing some of the healthcare providers actually funding lawyers and social workers and others to go into the community and address these issues. I'd like to see them also start funding organizers and being on the ground and in the community so that we can shift the power. I think ultimately, so many of the issues that we're seeing today are about disempowerment and subordination and standing on people's necks. And this is to shift that. One of the frameworks that the Legal Academy has talked a lot about, and we're now seeing in the Medical Academy, is the health justice framework. So it attaches directly onto the WHO conceptual social determinants of health model and has 4 prongs. And the 4th one was just recently added, and it's the truth and reconciliation, which is really uncovering the historic roots of how we got here, why bias is baked into all of our laws and policies, and why there's no material supports to help people get back to equity in place. So that's the first one. And the second is shifting power. Jamila Mishner at Cornell writes a lot about power structures, and she goes into the community to ask tenants and others, low-income people, what works for you, what interventions are working, why are you choosing certain over others, and how do we make sure that policymakers are going into the community and giving people the space to participate meaningfully in policy decisions. So many people in low-income settings are suffering from a diagnosis of toxic stress, which literally affects your ability to make decisions, to contribute, to learn, to do anything. And so having material supports, having the housing conditions repaired, those things so that you can participate effectively matters. The other piece is law and policy. Our laws and policies, from everything from budget to the enforcement of laws and policies, they don't shift unless the power and the truth and reconciliation changes at the same time. We can unpack every single one of the laws that resulted in the situations I mentioned with the pathways to health and housing, and all of them are flawed. All of them are deliberately recreating the power structure that already exists. They're based on feudal law. They were written by white landowners and with the goal of maintaining that power and the income and wealth that comes with it. And then the last is the material support so that we can actually rectify the tip.
Okay, yeah. You're getting used to my looks. So, I mean, and I'll just say for the students in the room, right? I teach contracts, which students often think is like far away from thinking about health, justice, and power, right?
Yeah.
But it is like deeply embedded when you think about rental agreements, right?
Yeah.
When you think about the ways that the government decides to like fund farming, right? The farm bill is something we could talk about. And then Professor Freeman mentioned. Professor Freeman, to you, and I will give you 2.5 minutes, and I'll give Professor Ogungbe 2.5 minutes, and then I will beg for another hour next time.
I'll try and take one. So it's interesting how you frame the question, like how do we get them to pay? But really, from my work, I just want to get them out.
Abolition, okay.
Yeah, abolition, reparations. Like if I had to sum it up in 2 words, that's what I would say. Yeah, I think, there's just no place for profit-driven corporations in feeding people through government programs. And it's also really important to give people enough money to eat. So through WIC, through SNAP, through maybe a universal basic income, just those kinds of stuff, because poverty is so tied to food access and that help. So I'm willing to stop there.
Okay, thank you. But really important, right? You guys need to go get the book. I think that is right, because the historical roots, it ties back to thinking about the structural realities. You've got to understand the whole picture.
Thank you. Does that take more time?
You get, I mean, I think she allowed you to reclaim her time. If I would stop talking.
Well, thank you. That's a very wonderful question. And I do like I kind of appreciate the way it's framed in terms of referencing models, framework, or just even work with work. So I'll give some examples towards the end, but I will start with a framework that we tend to use in my research and in a lot of work that I do. It's actually the National Institute of Minority Health and Disparities framework. It has that element of the multi-level influence in terms of how health and how social determinants influence health at the different levels, and how we can come up with interventions that, like I said earlier, target each of those levels. So for instance, behavior, how can we encourage people to make dietary changes to improve their health or to manage their hypertension better, as an example? One thing I think that I didn't say in the beginning, and I sort of assume that everybody knows, but I'm going to say it, is that, to your point, Professor Benford, cardiovascular disease is the top killer. We know that in the US and globally, and actually in most countries, like most people die from heart attacks and strokes and related deaths. And that's why it's sometimes usually easy for us to make that connection between social determinants of health and the top cause of death. But also, we also know that other diseases are impacted. So in terms of model, that's an example, but we also have other models that we use. But in terms of how we actually come up with programs or intervention, and I will answer your question about community-based participatory research, which you sort of wanted me to define.
Yes.
I will try to give a sort of like a broad definition, but this can be defined in many ways. I like to call it community-engaged research or community-informed research, but the old term, or the term that a lot of people still use, is community-based participatory research, which is really a collaborative approach to research that has equity embedded in it. So there is equitable involvement of all partners, which it is done in a way that uniquely highlights the strength of the partners. So when we are working, for instance, in some of my work, we work with faith-based organizations. We actually go to churches every Sunday and we go measure people's blood pressure and we talk to them about their health. How do we ensure that, number one, people realize why we are coming into those settings, and how can they be part of the intervention that we are crafting? It's not just screening people for high blood pressure, but we also want to ensure that their blood pressure is controlled. We want to ensure that those who have not developed high blood pressure, they keep it that way, as an example. So that's really how we do community-based participatory research. We outreach to the community. At the initial stage, it can be one way, But we begin to have that conversation, ask for feedback, then ensure that we are incorporating their voices. We do that with things like community advisory boards that we sometimes will have with community. We actually have these councils or these boards, and we have people come, every month. And we say, this is what we plan to do. What do you think? With that work in your setting? Well, actually, no, it may not work. We encourage you to do it this way. And we allow that to drive the research. We don't come as, the all-knowing researchers. We have our PhDs and our MDs, and we're going to tell you what works. Now, we may have some of those expertise, but we try to ensure that the community and the community residents are actually the experts. They can tell us really what's going on.
1 minute.
Thank you. And one thing I do want to say in terms of just intervention in the community engaged work is the word multi-level intervention. Sometimes it can be easier to collect data and to implement research that is really targeting. We're going to, do exercise class and encourage people to exercise more, as an example. But we also have found out that when it is multi-level, it is more impactful. So for instance, when we are targeting at the individual level, human behavior, trying to improve health generally at the individual level, but also at the health system level. What can we do? Should we incorporate social workers, community health workers, care coordinators? I was having a wonderful conversation with Dr. Patel before this panel about that. Care coordinators, how can we ensure that people know what to do when they get that new diagnosis and they don't know what to do, and they have, they don't have access to high quality housing, they are overwhelmed? How can someone really help them navigate that? But then at the policy level, what can change? Things like for health systems that have community health workers, should they be reimbursed? How can we ensure there's reimbursement for community health worker program? That's just an example. How can we, to answer your question about how to get them paid? Now that's where I like to talk about that as a researcher, the data, right? Presenting the data to payers, saying this intervention works. One of the new research I started to work on is a food access research. We're doing produce prescription, like actually having dietitians work with people and say, hey, this is a prescription. But we're not stopping at that. We're also providing produce to people. But we need to show payers, we need to show policymakers that this kind of intervention work and that they should invest in those kinds of interventions.
Which, right, and I think sometimes means using the cost benefit playbook, even if it's a really uncomfortable playbook, because, right, you each told us history and stories in which just being a good person is not what is going to get us across the finish line. And I think you guys need to bear in mind this concept of the structural elements, understanding the history, but also empowering communities, right? This is not top-down work. This is not me stepping in to be your voice. This is me being a steward of your voice and your interests. And there can be confusion in our profession around what the role is. So I will wrap up to try to keep us on time, or do we have a few minutes?
Yeah, we have about 3 minutes. The chat has been a little quiet, but if folks in the room have
So
questions,
I have questions. Questions. So what does success look like?
You're asking me.
I'm looking at you, but I'm asking
Yeah.
everyone.
I think it's the quote that you had up from Margaret Whitehead. Do you remember how that went? That everyone has the.
Oh, the Maya Angelou quote.
There was one from Whitehead as well, who
oh, yeah.
Marta Sen and Margaret Whitehead collaborated and really defined what health equity has to do with social justice. And it's really having the resources and the ability to achieve full health and to access society and to flourish. Exactly. That's exactly the word. And one thing we have to keep in mind is, so the pandemic is a perfect example where we had so much money going to the states. We had so many allowances that they could buy into, like the food SNAP, supplemental nutritional.
Expansion.
Yeah, there was a huge expansion that you could add. You could give people more money for food. Not all the states signed up for it. They had that money on the table and they walked away from it.
Like Medicaid expansion.
Like Medicaid expansion, exactly. And the Medicaid waivers where you can actually address now, so many have been approved to address social determinants of health, but only less than a handful of states have actually tried that or applied for that. So there's all of these interventions, there's resources. We had $6.5 billion in rental assistance distributed across the country.
and we set up the infrastructure to literally halt the eviction system to zero. We did it. And now we are right back up surpassing historic levels. But we did it. So we had the infrastructure in place and made a policy choice to go back to the status quo and to keep people from rising. So I think success also looks like putting people who are affected in positions of leadership to be the ones making the decisions that are going to affect their lives, because they're the only ones who know what will work in those settings.
And accountability, right?
Absolutely.
Any final words, Professor Rumbe, Professor Freeman?
Yeah, I'll just say something about that. I mean, I think that the stories we tell in society are so important, because why do states refuse things that work for their constituents? It's because they believe that those kinds of help are entitlement. You know, it's a history of racism that explains why they won't take them, they won't give it out. They see it as handouts instead of something that lifts everybody up.
And we hate poor people, right?
Yeah.
Like, that's not, the shame of school lunch, the way we think about poverty in this country and bootstrap mentality. Go ahead, sorry, I'll get off my soapbox.
Oh, no, absolutely. I thought maybe you want me to show my lunch shaming slide.
Professor Gungry? Oh, go ahead, and then, yeah.
Well, just not only do we hate poor people, we blame them.
Yeah,
And if they're Black or Hispanic, we blame them.
double
more.
down,
Yeah.
yeah.
Yeah, exactly.
I trying to think of something really profound to say, but here's what I'm going to say. I think success will be thriving communities and health equity, like you said. I think it's a be the recognition that communities and we actually individuals, we are experts in, like, we can better describe our situation. We can better describe the determinants of our health, and the recognition that policy, health systems, payers, all of these key partners really should not be the only ones driving that or making those decisions. Like, communities should be at the forefront of really demanding and the forefront of the change making, and should be allowed to be.
It's about a reallocation of power, right? And in large part, right? And following the rules that you set. So I want to thank you. I wish we had more time, but I look forward to being in conversation with all of you. We will make sure that students have your information so that they can read what you've worked on. But I do hope that you begin to think about conversations in concert and not in silos. So thanks so much for being here.
All right, so our second panel, Improving Health Outcomes Through Medical Legal Partnerships, is going to focus on the role of medical legal partnerships and how they're operationalized to empower providers and communities to increase access and address social determinants of health. My name is Hallie Hoffman. I'm a member of the brief and the symposium director, and your moderator today is Michael Anneton. Michael graduated from Michigan State University College of Law. He started his legal career as a judge advocate for the United States Marine Corps. During his 4 years as an active duty judge advocate, he served as a prosecutor for the Marine Corps Air Station in Iwakuni, Japan, and as a criminal appeals attorney at the Navy Yard in Washington, D.C. After serving on active duty, he served as an attorney for the D.C. government, and during his 10 years with D.C. government, served as a prosecutor with the Office of the Attorney General, as an attorney advisor with the Office of the State Superintendent of Education, the General Counsel for the State Athletic Association, and also as an administrative law judge for the Office of Administrative Hearings. He left DC government when he and his family moved to Maryland, and he currently serves as the Deputy General Counsel for this is a mouthful, the Maryland National Capital Park and Planning Commission. He continues to serve as a major in the Marine Corps Reserve, and we are thrilled you're moderating this panel today. So thank you so much.
No, thank you for having me, and welcome. I guess you guys have been here. So yes, as Hallie said, I'm the moderator, and again, I'm going to go ahead before we dive in to this discussion. I'm going to introduce our esteemed panel, because this is an incredible panel. So we've got Professor Cannon, who co-founded the Health Justice Alliance, which is a medical legal partnership in Georgetown University. She serves as the legal director of the Alliance's clinical program, where law students and medical students, as well as pediatricians, partner to provide housing, food, economic security, and access to healthcare for DC's vulnerable population. She also co-authored the Special Education Advocacy textbook, as well as the Fetus, AIDS, and the Law. We also have Mr. Cass, who's the supervising attorney on the Healthy Together team at the Children's Law Center. It's a medical legal partnership here in the District of Columbia. His work covered education, housing conditions, public benefits, and Medicaid appeals for under-resourced families. He also conducts interdisciplinary trainings for medical providers, patients, and pro bono attorneys. Before joining the Healthy Together team, Evan was an advocate for the children in the neglect, adoption, and custody cases as part of the Children's Law Center's Guardian Ad Litem program. Next, we have Ms. Dooley, who is a supervising attorney in the Public Benefits Law Unit at Legal Aid DC. She represents clients in a wide range of public benefits matters, including TANF, SNAP, Medicare, Medicaid, and unemployment insurance. And prior to joining Legal Aid, Ms. Dooley was a senior policy counsel for the NAACP Legal Defense and Education Fund. And then last but not least, Dr. Patel is the medical director for the Improving Pediatric Asthma Care Clinic. She's also an attending physician in the Children's National Emergency Department and an assistant professor of pediatrics at George Washington School of Medicine and Health Sciences. Currently, her work focuses on the geographic predictors of health outcomes using GIS and other tools to map housing complexes associated with asthma, firearm violence prevention, and suicide prevention. So that was a lot really quick, but I mean, that's just a glimpse of the talent that's up at this panel. So with that, we're gonna dive right in to these to the issue of improving healthcare outcomes, especially for vulnerable communities through these MLPs. So we're going to start just kind of on the macro. We're going to talk about who is involved in these partnerships, these medical legal partnerships, which communities are served and why they are served, and then the funding resources that are required for these partnerships. So yeah, that was 3. So break it down. So who's generally involved? And anybody can start. Feel free to jump in. But who's involved in these medical partnerships? Generally.
I'm sorry. I'm volunteering.
So you actually often find MLPs associated with law school because there's also often a medical school that is tied to the university. And so that's a great way to connect. And so Yael can talk more about that. But we also find them in some specialty medical settings. So my practice is in pediatric setting. A lot of cities have them in veterans hospitals. We don't have that in DC. I think that's a space. Maybe one of you will start that MLP. But those are some of the spaces we often see them in, or different ways of targeting, homeless population. People living in shelter might be a population we want to access. And there's some new MLPs in DC right now that are targeting different health criteria. So there's a cancer MLP, there's a prenatal, neonatal, perinatal, that's the one. Perinatal MLP as well. So there's different ways to kind of bring.
Anybody else want to jump in on that?
I can add to that a little bit, and maybe it's worth saying just a minute about really like what a medical legal partnership is, although that continues to be a dynamic question that we can talk more about today. But the model was really born out of frustration on the part of physicians. So there were physicians at the Children's Hospital in Boston who were serving kids who were coming into the pediatric emergency room. And Dr. Patel can speak to this in vivid detail from her work today, but this was back in the 90s, and they were finding that kids were coming in with very serious asthma attacks, and they were giving these kids the best possible treatment, and the kids were not getting better, and they were coming back in sometimes with even life-threatening asthma attacks, despite the doctors doing everything that all the textbooks say that they should do to treat these kids. And when they started talking to parents, they realized that many of these kids were living in the same types of substandard housing conditions that you heard Professor Benford talk about. You saw that picture during the last panel of that very multi-bathroom, and you heard her describe the child with mold next to his crib, and they started hearing those types of stories, and so they encouraged those parents to, you know, get those conditions like mold and roaches and rodents fixed, so that those kids could get healthy. Well, those parents came back and said, you know, well, tried to reach the landlord, they didn't respond to my call, or you know, they said it was my responsibility, or that, you know, like Professor Benford was saying, sort of blaming the tenants for being, you know, for keeping a dirty unit or something like that. And we also, they also heard stories of the city's housing authority owning housing with these problems, and also pushing it back onto the tenants. And so the doctors realized they didn't have all the tools in their toolbox to get their patients healthy. And they had this idea of reaching out to some partners at Legal Aid in Boston and Harvard Law School, and actually to bring a lawyer into the hospital. And they gave that lawyer a pager, and just like they could page a cardiologist to the emergency room, they could page the lawyer, and bring that person in to start doing some of this legal advocacy to ensure that, you know, people were living in the safe and healthy housing conditions that the law entitles them to. And they started to see that with that medical legal collaboration, they could get families healthy. And so since that sort of launch and the beginning of like the use of that term medical legal partnership, the model and the movement have really spread, and they're now in almost every state in the country. And you find them in federally qualified health centers, you find them in large hospitals and health systems, you find them at medical and law schools, like at Georgetown, like Evan was saying. You know, our program has a lot of medical students learning together, and I'll just say 1 minute on what that does, which is, and all of you are experiencing that by even just being in this room and getting to be in amazing conversations in the classroom with your incredible health law professors here at WCL, that it matters so much how we learn when we're in the most formative years of our career formation, right? And so to have medical and law students learning about and practicing health justice as part of their professional identity formation means they're going to go out and practice differently, and ideally transform both the systems they're working within and the systems that are kind of around and exerting forces that we were talking about.
So, you know, when you were speaking, you mentioned, you know, helping out these populations that are underserved. I mean, it kind of reminds me of the whole, you know, there's a medical desert, there's a food desert. So there's these populations that aren't getting adequately served. You know, how are these partnerships getting funded? Typically, when you're talking about underserved communities, there's not a lot of money behind assisting underserved. So where's the money coming? Like you said, there's lawyers and hospitals. Like, is it just, you know, I'm not saying just in that way, is it only students? Or is there money that's kind of propping up this effort? Anyway.
I mean, for Impact DC, so we've been kind of going back to the history a little bit. Dr. Stephen Teach founded Impact DC in 2001, and he was trained at Boston. So he brought kind of that model. He's also trained in emergency medicine physician. We see these children, and it still happens despite Impact DC being around for 20 years. 22 years this year, where kids repeatedly come back to the emergency department for episodic care instead of going back to their primary care provider. In terms of the funding for that, I think kind of some of that was alluded to in the last panel in terms of really showing the insurance companies the data. And so that's how Impact DC was born. And some of the payment in terms of the medical side, at least in terms of medical side of the medical legal partnership, comes through that value-based care payment that we get from Medicaid. And all of DC Medicaid, essentially, we have an agreement where we have a shared cost savings. We share data with them, and we save them money because we reduce the emergency department visits and hospitalization for patients who come through our program. We actually get referrals from the DC Medicaid of patients that repeatedly either use their albuterol, the rescue medication, or come to the emergency department, or don't go to their primary care physician. So multiple ways of referrals. In terms of the legal portion, I'm not exactly sure for the CLC, but we have written grants together, many grants. Back, like some repeated back to back, and even lost the funding and we feel it. So we, like maybe years or sometimes months where we don't have as much funding, and the capacity of the medical legal partnership to help our patients goes down during those periods. So we've applied for various different grants, build grants, et cetera, but our portion is mainly sustained through Medicaid. Of course, we also apply for grants to supplement that. But so I would say, charity foundations has been a large part of it, and sometimes the sustainability is not there because of that. And then I also feel like as we improve this and that sharing the data more, so the medical legal partnership for us has actually meant we could take it to the next level. So I can talk about this a little bit more later, but we've created this pretty impressive dynamic healthy housing map where we have our data. So we have a population health registry of every single patient with asthma in the District of Columbia, their utilization, their hospital utilization, multiple other demographic factors. And we've overlaid it with Children's Health Center data in terms of cases that they've filed and publicly available housing violations data. And you can actually go see where the overlap is in terms of where the children with the highest morbidity mortality live and where the most housing violations and what those housing violations were for, to kind of really start making policy level decisions. Because in DC, we actually have pretty good housing code for healthy housing. We write letters. We have a standard letter that we've been using for at least 15 years, the landlord letter. That's our first pass where we essentially hand it to the family. It's tailored to their needs. So we actually, the pictures that they showed, we see those pictures in clinic. Every single time I'm in clinic, the parent will say, this is my child's bedroom, if you see it. So we write a very detailed letter based on what we've essentially ascertained from the medical history with the medical utilization. Then that's the first pass. And then if the landlord is not receptive to that, we refer them to Children's Law Center to kind of take the case further. But with this map, instead of doing one-on-one advocacy, I think there's a chance to do building or unit level or landlords, because some of the same landlords are owning not rocket science, but the hot spots are sometimes the same landlords in terms of who are not doing anything. And when you fix one unit, because we do have home remediation as a part of it, often if you don't fix the surrounding units, then essentially it's not prevention. It's just.
I just build on one thing Dr. Patel said. I just want to put a pin in because it's actually really amazing work, which is that we worked with Children's to get all this medical data to be able to prove to the Medicaid providers how much money we're saving. And the money was $10,000 per child per case. So that was a huge savings. And the barrier to having that communicate is huge, right? HIPAA exists. So we can't just get all these medical records from Children's. They've got all this great data. But for us to work together and collaborate, there was actually some legal barriers there to moving that forward and getting that research. But we think we're the second partnership in the country to be getting Medicaid funding to support an MLP. And we think that's a huge untapped resource where we're saving them $10,000. They've agreed to pay us $1,000 per case, basically. Yeah. Great, everybody kind of wins. We get some money, they get some money. That's how we're funding it. But there's the barriers of things like HIPAA that slowed that process. But I think there's a lot that could be done there to expand. Like, who is the winner when we partner together and we improve the health outcomes for our family? Medicaid, to some extent, is a winner. They're not having to pay for all that healthcare. So we're really proud of that, and we think that's really amazing. But it's a tough thing to set up for sure.
Yeah. And just the middle ground, I will say, in terms of what we had with owners, essentially families who own their homes, where they've owned it for generations, that need work. There are private organizations that we work with as well. Yamad is the main one in DC that helps, and they raise money on their own to essentially start helping these families who can't refurbish their whole house but need it for their child's health. And so there's those kind of patchwork in between organizations as well.
Awesome. Just real quick on the whole, you're mentioning the barriers, those legal barriers like HIPAA. If you were able to crack that nut, if I can use that phrase, what's the replication like? If there's MLPs all over the region, all over the country, like are MLPs speaking with one another to help each other, or are we not to that point yet, where it's like, hey, we're still trying to figure it out ourselves, So we can't really then assist other MLPs. Is there a lot of coordination going on as far as that's concerned?
And I can speak to a little bit about the population health registries that are coming out that I think are breaking down some of the barriers. So because that was a big part of this as well. So our data use agreements in terms of our children's hospitals are becoming when we're creating these youth health population health registries, children's well centers are the only ones who want that data, right? So for instance, the Department of Health has wanted that data, limited data use, other policymakers want that data, states want that data, or regional data sharing agreements. So I think as population health registries become more common, and I think that as EMRs are improving and health information exchange is improving, I think that'll be there. So I think there'll be a format for it. I think we wrote, I would say, like it was years before some of that was even there. And so I feel like it might be easier for other places because these data sharing agreements are almost becoming more commonplace because it's necessary and the data is there.
And I would just add that there is a lot of coordination and conversation among medical legal partnerships across the country. And for those of you who are interested in the model, I encourage you to go check out the website of the National Center for Medical Legal Partnership, which is actually run out of GW's Public Health School and at George Washington University across. But it's actually a national organization. And so if you go online, you can see a map that shows, if you're interested, is there a medical legal partnership like in my hometown? And who are the partners involved? And there's a ton of resources, including working through some of these issues around data sharing and confidentiality. And there are national conferences that get put on that students can attend as well. And there's different sort of like webinars and conversations, including around funding and the role of various federal agencies like the Veterans Administration is funding medical legal partnerships because they realized how important to the health of veterans getting legal advocacy, particularly around benefits and housing, could be. And there's various entities that have sort of supported the medical legal partnership model and kind of raised the specter of it. So the American Bar Association, the American Medical Association, the Association of American Medical Colleges, all of these different entities, they have sort of formal resolutions supporting this model. And I think it's because of some of the things that Dr. Patel was saying that we were talking about in the last panel of sort of, we have to use the playbook of return on investment. And fortunately, there is a growing playbook here. There's a growing evidence base that can be built.
Thank you. So we've been talking a lot about how, you're treating somebody's in the hospital. That's one way. You got your lawyer in the hospital, you can get paged. You guys have painted a nice picture. That's in the hospital. But what about the community engagement on a larger scale? Like if we want to reach people when they're not in the hospital, or what are the avenues of approach to getting us there? Like it's kind of.
So Impact DC, and maybe it's unique to DC because Children's National actually staff school nursing program. We use the schools actually a lot. So schools are our second level of connection. So when we have repeated failures, for instance, a patient's been referred to an emergency department or hospital or their insurance company and no showed multiple times to Impact DC, the next step is going to be actually trying to get through school. Now, data use stuff comes there too. Kind of get around that on a one-on-one basis because they're actually they're caring for that child. We're caring for that child, so we can get around HIPAA in terms of that a little bit. But in terms of population health approach, we're still kind of trying to tackle some of those barriers in terms of data use between schools. But I think for us, it's in schools. We also in DC have something called connected schools. I don't know if any of you are familiar where certain schools are designated as connected schools, where they're supposed to be the community centers or hubs for that neighborhood. And so they're trying to bring in all sorts of resources, like even public benefit resources to the schools because parents already trust that as a source for information for help. So I feel like that's another kind of avenue of getting around and how we get like in their community.
We just started, we have a new community lawyering team, and they're launching things, lawyer right sessions with DCPS schools, where it's not directly related to a medical legal partnership, but it is providing these resources to families so that they know that we are here and they can come to us with public benefits issues, housing issues, and that's a way for them to get in our door and for us to connect them to our resources and other resources.
Awesome. So then where are those teams located? Since where do you guys the central, or do you guys go out?
They've been going out.
Okay.
So we have our main office in the Northwest, which is not very centrally located for most of our client population. We have another office in Southeast at the Big Chair in Anacostia, so that's a place where people can come. But they've been going to farmers markets, to schools, to libraries, and setting up programs and presentations where people are, where it's easier for them to come and reach out.
And you just brought up something else, the ARC, and I think Big Chair are two examples of how co-location of services actually brings people together. So we actually published a map, I would say now 15 years ago, where you can see primary care access and asthma utilization. And I would say the landscape has changed because children have made an intentional investment to kind of the medical desert kind of phenomenon in terms of like where we can improve primary care access so they don't have to come, especially east of the river, they don't have to come over to us where the main medical center is. And I think the co-location of services that the ARC and the Big Chair have made a difference there.
Yeah, and just for those who don't know, so the ARC is the Town Hall Education, Arts and Recreation Center on Mississippi Avenue in Southeast. And so it's a community center that has all kinds of services under one roof, including Children's Hospital having a clinic there, and there's arts and there's education. And there's fitness and all kinds of things under one roof, really deeply embedded in a community. And the Big Chair is, it's a landmark. It's literally a big chair in Anacostia, in Washington, D.C. that used to be outside of a big furniture store, but that the landmark remains, but the building is now a place with a lot of social services and government services that people access. So for example, like the Social Security office is there, Children's Hospital has a clinic here there as well. And I was just going to add one other thing about sort of your like community reach question, which is, you know, that medical legal partnerships really offer an opportunity to sort of bring access to justice to the community, to a place where people are already going, right? People are already coming to the doctor, especially to the pediatrician, which is why a lot of medical legal partnerships, there's a lot of reasons why a lot of medical legal partnerships focus on children, but one of them is that that is a pretty frequent healthcare access point for many families. It also allows us to get very upstream in the life course. We saw a slide about life course in the last panel, and so these models that, you know, reach communities like the like school-based health centers are really, really important because medical legal partnership then not only provides low barrier access to healthcare, it provides low barrier access to justice as well. And at Georgetown, in addition to Georgetown also has two high school-based health centers at Anacostia and Roosevelt High School where we're working, but also runs a mobile clinic. So it's a full pediatrician's office on wheels. They have behavioral health integrated. They have reproductive health integrated. They have support for LGBTQ teens. They have fitness and nutrition services. So a lot of the types of issues we actually talked about on the last panel are all kind of on wheels. And the way that Georgetown's Division of Community Pediatrics decided where to park that was to look at these maps of where are the primary pediatric care medical deserts in DC, and where are kids really not getting to the doctor. And so the van pulled up at the front door of many children. It parks right in the middle of some of our biggest public housing complexes in DC. It makes it really easy for kids to come on the van and get access to healthcare, and when they're there, they get a legal checkup as well. And they get asked about different of these sort of structural and social determinants of health that we talked about on the last panel to figure out where legal advocacy is really needed to remove those barriers to health and to address those health harming legal needs, which is what MLP.
That's awesome. And before we move into the social benefits kind of plan, the mobile clinic, just real quick, and that's huge. Like, can you? I don't know if you can, but if you could, can you describe the network? Like, is there one van? Are there 20?
Yeah.
Maybe like how many are we talking about? Which
Yeah.
numbers? Like,
Yeah, well, I can describe the model that Georgetown has, and I know Children's Hospital long had a model because I used to collaborate with them when I was at the Children's Law Center in the early days. But Georgetown's model has two vans. So one is the primary pediatric van, and then the other van is for nutrition, fitness, and health education services. So it has both vans have patient meeting rooms. So it's literally an RV. And when I should have brought a slide to show you, it's really cool. But you can also look up the MedStar Georgetown Division of Community Pediatrics and see a picture of the van and the high school-based health centers. So it can really come to life for you. But it's like this giant RV, and it parks, like right on the street. It's massive, and when it's parked, it has these like bump outs. So that when it's not moving, the sides can literally open, and all of a sudden you have a number of small patient rooms with kind of a waiting room in the middle, and the driver of the RV is also like the receptionist at the health center. Scott, so he parks and Scott greets the families that come on and checks them in. There's a little waiting area. Everybody gets an iPad in the waiting area that has a mental health screening for each child, and also has this legal checkup. And those checkups are then connected with the electronic health record. And so how the families answer those questions, the provider in the little tiny patient room of the bump out of the RV, can see, how families have answered those questions. There's a refrigerator where they store the vaccines. So the idea is that anything you could get at Georgetown's like fancy pediatric clinic right around the corner from here in Town, you can get on that van. And then in many of the communities, and they've been going, they're now going on 2 decades in the same communities, and they have some families that are coming, like the next generation of kids is coming on that van, and people know, like in this neighborhood, in Richardson dwelling, in Clay Terrace, and these like large public housing complexes, the Georgetown van is there on Mondays. And if you need to see the doctor on Tuesday, you can just go like a few neighborhoods away. And the fitness and nutrition van pulls up to some of these locations. They also have partnerships with schools, and kids can like come on and families can come on those vans, and they can also get sort of health education and health literacy support as well.
Yeah, Children's has similar vans. A lot of them are grant funded through the ARC actually. There's a lot of dental visits in some areas with dental issues, immunization drives, essentially where they park in front of schools and get kids vaccinated who are under vaccinated. It's happened with a lot of kids were falling behind on vaccinations with COVID. So a huge vaccination drive happened this past 2 falls, to essentially catch kids up on vaccinations. We've actually toyed with the idea, and I've done it a few times, but in terms of systematically having Impact BC clinic on the vans and parking in front of the school, essentially kind of getting asthma action plans, school-based asthma care up to speed, school by school. So eventually we'll get there. But because we're tracking, we're able to track now because we have electronic asthma action plans, who has an asthma action plan, who doesn't. So they're not really school ready. So that's a huge area of improvement. And we can easily park the van. And I think telehealth has been another kind of innovative space for this. We did a lot of video home visits, actually pre-pandemic, and that allowed us during the pandemic to we went all telemed for our Impact BC, but it allows us to bring all our partners together in one place. We had our housing partners on, we had the doctors on, we had sometimes 2 parents if they live in 2 different households, all on one call, addressing all different things. And the other, I thought from a provider's perspective of a video home visit was they can actually show you what was going on. And you could also witness a little bit from a provider's, like in terms of why maybe the child may not be getting better, the chaos of the home and what's going on and how quickly they can get their medication when you ask them, show me how you use your medication. And all of that it was actually really, really great in terms of how much information you could bring between the population.
So in both of your experiences, is this something, these mobile clinics, do we need more? I mean, is this what we have right now? Is it enough, or do we need more? Do we need more funding for those, those clinics on wheels, right? Do we need more, or is this adequate right now?
I think we need more, but more than that, we actually need more bricks and mortar healthcare in these neighborhoods, because the van is wonderful and offers a lot of services, but it can't do everything that a larger health clinic can do, and it can't see the volume of kids, right? I mean, there's only so much space on there. And actually, we really felt that during COVID because then there were a lot of restrictions from the Department of Health, how many like literal human bodies could even be on that little van at the same time. But you know, the fact that these neighborhoods are medical deserts and food deserts in the first place, and these are the same neighborhoods that we saw kind of on a number of maps in the last presentation. You know, those neighborhoods require like really, really deep investment so that we don't have these big gaps in care and resources.
And the other thing I think that will help that is transportation. So often I feel like even just allowing ease of access of transportation and removing stigma of like, how do you get to your, I mean, I have patients who take bus after bus after bus to get to me. And I can't imagine trying to get with my two, you know, my siblings of my children and the child with a doctor's appointment all on a bus to get across town, to get to a doctor's appointment. So I think transportation for health related visits is another big area which can help kind of this medical desert.
Sure. And I want to go back to that in a moment, but I do want to touch on how the social benefits playing the TANF, SNAP, like how is that playing in these partnerships?
Yeah, so I think we have worked together, and I know Yale's worked with Evan as well on kind of clients in common between us.
Yeah.
Helping get access to things like SNAP and so SNAP is supplemental nutrition assistance programs with what used to be called food stamps. It's providing money that can only spend on food, on cold food for families. And then TANF is what used to be known as welfare payments. So it's cash payments to very poor families. And both of these programs have issues. They're basically designed to keep people in poverty. The amounts are extremely low. I think for a family of, I don't remember the TANF for a family of 2 or 3 is like $500 or something. You can't live in DC on that. Like SNAP for one person is $291 a month, which is again, like not enough to actually afford like healthy food per month per person. And the systems themselves are also very poorly designed. They really don't want people applying for them. So you have to go through a lot of steps and processes, and like they request all these documents from you every year to like renew your benefits. So it's a system designed to keep you in poverty and also show how much they really, as you were saying on the last panel, as they were saying on the last panel, don't like people who have to use these programs. I don't even know if that answered your question. I just went on a rant.
That was extremely insightful. So then, you know, if the system is well, if I can use the phrase, we're broken, like what do you foresee? Like, is this going to require a legislative fix? Is this going to require like the MLP as a whole to get out there and push for changes for that? Like, where do I mean? Because these programs, like you said, they were once known as one thing. Now they're here, so they've been around forever. So what do you see as the course of action to address those issues?
So even if the system worked perfectly, it still would not be enough for families. So there would need to be kind of congressional action to increase the levels of assistance so that a family can actually live on it. So within that, I think MLPs can really help with kind of fixing some of the problems within the system as it currently is. A lot of people don't know how to access it, so having like kind of increased support and communication among service providers like us can help people kind of get in the door. But then it would be Congress who like fixes, like updates the building or whatever, like comes through the door to them.
So, and then your team, like as far as social, like, can you describe? Maybe somebody did this a little earlier, but can you specifically? I know we got the lawyers, we have doctors, we have potentially some social workers, maybe. Like going back to your point about, hey, we need transportation. Hey, we need brick and mortar. Like, do we have other government officials on these teams? You know, from the Department of Transportation, from planning and zoning. Like, have those individuals been, you know, reached out and touched yet, or are we still trying to get? I think that's an answer in and of itself, right? Like that's
transportation. So insurance, I mean, you can call the number on the back of the card, but I mean, systems wise, like I work in the emergency department in the medical center in Southeast, and no one comes. I mean, we have medical Uber, but we try to avoid, because our ambulances are always backed up, where I want to transport a patient from
the United Medical Center campus to the main hospital for surgical consult or admission or whatever it is, and they just don't come. I mean, it's really frustrating, right? So it's like from a systems perspective, I think it's more than just offering free transportation. It's kind of building the structure to actually have that.
I work in the space of SSI benefits, which is public benefits for disabled kids. I work in. And you can see that some of it's just plain funding, right? Like we have inside names and numbers that we're allowed to contact as advocates, but they're not publicly available. They would be so overwhelmed. Right? So like I can email somebody in the office, the local social security office, but your average person on the street is in trouble. Has to go stand in line at 8 a.m. to maybe get an appointment. Security. Social Security still does a lot of things by fax, right? Like we are not in the 80s anymore, right? And that's just pure funding, right? It's a hard job. Somebody told us once it takes 2 to 3 years for a Social Security claims examiner to be competent at their job. Like 2 to 3 years, I can train somebody to be a lawyer in 6 months. So like, not rocket science, right? Like what's going on? But they have the turnover, and because they're so overwhelmed, like they continue to have the turnover. So some of it is pure investment in improving systems. Like anyone who's filed taxes has kind of gone through a similar bureaucratic dinosaur, right? Like that's what we're talking about. Bureaucratic dinosaurs. Are we investing in the technology that we have? Are we getting the people in? Are we valuing the people that are getting services? Like, I think it's a money thing. I think we can triage, we can have our inside, I know us on this team, we've got inside numbers, right? For different agencies, we've got a good person that we all know to contact at this office, but your average person on the street shouldn't need a lawyer to get food stamps, to get disability benefits. They just shouldn't need us, and yet, because they're so working.
And I think what you said about multiple service providers, like the cross connection between different needs. So in 2017, one of our asthma educators, they're all lovely people, like they're fresh undergrads and so much energy. All these families keep asking us for this help. We need a screener. I was like, okay, go make a screener. And so she made a screener, we've iterated on it, and now we have a 5 needs-based screen. And TANF food stamps is on, it's like SNAP is on there in terms of if you want help with it, check it and then they essentially refer. But it's all together, all these families need, and all of it usually. And I think this utilizing these cross resources where we're seeing the same families, I think is another important thing to kind of make sure that strong connection between our referral agencies.
And if I can just add that I really agree with Evan because in the best case scenario, we'd all be out of job. Except maybe Dr. Patel. We work university. There would be no need for emergency room. But I was just going to say that sort of building off the discussion in the first panel around sort of power building and really letting those who are most impacted lead. I think that with your question about talking to the Department of Transportation and community economic development folks in government, I do think that we have opportunities in the work that we do to really look for chances to sort of elevate the voices of the people that we're working with. And so that can come in the shape of sort of what Nicole is talking about, how do we have some of these sort of system fixes? And then also, like she was talking about, how do we have sort of bigger structural change? And so, for example, when we start seeing a lot of patterns, a lot of times we'll speak to our clients about are you willing to tell this story? Are you willing to go to the DC Council? Are you willing to go to this DC government agency and sort of talk about this experience? Because we're seeing this a lot, and this is a system fix that is needed. And that's sort of this concept that has kind of grown within the medical legal partnership movement called the patients to policy approach. And this idea that medical legal partnerships and the families that we serve can see the gaps and patterns and problems with the implementation, with the enforcement of the law, or with just the law just being a total hot mess and in need of complete kind of restructuring. And so, it has become increasingly important to me to look for opportunities for the families we serve to directly tell their stories. And there's some kind of coalitions in DC that are really committed, like the Fair Budget Coalition in DC has a constituent leadership program, and we've had some of our clients join that, and they are getting paid to be part of a program where they're getting training around budget and policy advocacy. And then they are going to the DC Council and saying, here's how we need a radically different budget for equity in DC. Here's what universal basic income has to do with health. And that's a very different conversation than just like fix this glitch with the TANF system. But both of those things kind of, I agree with Nicole that like we need to be doing advocacy on both those levels. And we have a lot of tools that allow us to do that, both as health care providers and employers.
Sticking on this patient to policy approach, and correct me if I'm wrong, because I mean, from a legal perspective, I know there can be a lot of like tactical moves, getting people what they need. But when I'm talking policy, DC Council, even in Maryland, the General Assembly, like they only meet for a certain amount of time. It's like moving mountains to get a lot of legislation passed. Do we have, and it's in the landscape there is very difficult to navigate just in general. So do we have like, partnerships with I don't know, law firms or like on a grander scale in that level to kind of push these things through? Because you said you have internally a lot of numbers, right? You guys share numbers. It's the same with lobbyists, right? And a lot of them are lawyers. So are lobbyists, and I know sometimes lobbying can be a bad word, but is that another kind of arm that you hold on?
I feel like DC is somewhat unique because we have a very sympathetic council. So the DC Council, I think many of them listen. We have good laws, right? And then it just, you get the law and then like nothing happens, right? Like this year they passed, or last year passed a law to increase SNAP benefits for everyone. And the mayor was like, sorry, we're not going to do that. So we had the law, we had the money. But it came down to like that one lady who just so it's hard. Sometimes I get a little bit frustrated. Sure. We pull people together, we get everything done, and then like Bowser is like,
right.
That being said, it is like we have clients who we invite to speak before council every year, and I think they do listen. And the agencies also listen, so they tune in. We've had with the Department of Employment Services, when we've had clients testify, call them while they're testifying to be like, oh, sorry, we paid you. Please shut up.
Right.
So I do think we have an audience. It's just like the devil's in the details of actually implementing everything.
And I know, so far we've talked a lot about, the kind of the housing aspect of this, the asthma and the environments that can anybody speak to the food, like the food aspect of this? You've got these mobile clinics, you've got some brick and mortar, but as far as access to health, food is one of those issues that that's one of the sources of a lot of health issues. Can anybody talk to what? Oh, give me the cane. Yeah.
It's time for questions if we have any. In children's diabetes, our diabetes center has done an excellent job. We actually have a food pantry in our hospital, and each family moves with a bag of food, recipe cards. There's actually a kitchen so they can get trained on how to make healthy food, and diabetes visits are quite frequent because they have to monitor their blood levels and adjust their medication. So they actually come in quite frequently and they get bags of food. We've tried to replicate that model with impact in our patients because obesity actually is an inflammatory condition that has a significant risk factor. And we actually saw it play out during the COVID pandemic where our obese asthma patients were the ones that were really, really sick. I think it's just space. We don't have, and at least so far right now, we don't have another big enough space to keep all that food in our hospital. The ARC is another location where they have a pretty good food pantry system, and it's a prescription. They get it, they sign up for food, and you can get food delivery. So I think there's a model for it, and Capital Area Food Bank has been an excellent partner in that for us. But it's a huge problem. There's a huge
connection. And just wanted to quickly say something about the housing. You know, we talk about it in the sense of like kids with asthma already getting exacerbated. But I think what's not talked about is a young infant growing up with mold around them and how they're sensitized to mold. And then now you've essentially created a problem when you could have prevented a problem in the first place. So this child could have grown up without asthma and then now is growing up with asthma because of the house that they're living in. So I feel like there's this prevention aspect of it that people don't talk about. It's just more like keeping kids with asthma out of, in health, but it's actually preventing asthma. And that's why you actually see prevalence, not even just morbidity, prevalence of asthma disproportionately affected in wards 7 and 8. And that's not because of, just because.
Right, there's a reason.
There's a reason, there's a reason for that.
Thank you. So I got slapped. I'm done. We're done.
Are there any questions that folks have?
A lot of your conversation was about public efforts to increase these things, SNAP, and things like that. But Mr. Capps, you mentioned that you saved Medicare, Medicaid, $10,000 per patient. How do you get the private sector, specifically the insurance sector, involved and present to them that this is going to save you money to invest in people and make them?
I love that. You want to take it on? And then the introverts. It's interesting, the intersection of, so we're not a legal services corporation, meaning we don't take legal services funding that would restrict our policy access. But the clientele that we serve, loosey-goosey, but like by and far is low income families. So we actually aren't getting a lot of families that come to us who are on private insurance. I would say probably 95% of our families, the kids are on Medicaid, and Dr. Patel can probably speak to this more, but we have pretty good coverage of health insurance for kids in DC, pretty expansive. And a lot of those kids are on Medicaid. So for us, it made sense to go the route through Medicaid. So there's a large overlap between who has Medicaid and who's having these poor housing conditions. So that maps on very nicely. Our families who have private health insurance are more likely to have more resources and are less likely to live in those houses that are full of rats, mold, things that exacerbate that. So it's that nexus between poverty and
I would agree that impact DC population is very similar to what Evan's talking about, but the Pediatric Health Network is actually taking on some of these private insurers. Children's National essentially runs the Pediatric Health Network of all the private and Children's National pediatricians together, and they essentially come together because one pediatrician's office can't get the best contract for their patients. Essentially, to come together and form coalitions, and in this coalition is a lot of this value-based care model. And I think in that model, there's probably room for that same thing in terms of if we can show to this private insurer, because you get large pieces of data when you put primary care pediatricians together, that if we do X, Y, and Z, we could save this insurer your patients because they're keeping data now improvement, then I think there's room for that. But I think it's, like I said, the data revolution in healthcare will probably help that a little bit. It's still slow. It's really frustrating in terms of how we document and how we're going to get me started with like how we document, and it's really for billing instead of medical care, and how we can't document in a way that's meaningful to actually extract the data. So I think it's slow, it's coming, but I think eventually when we have better data systems where you can extract data by insurer, saying Aetna, all your patients that have been at Children's National, they live in these conditions, and if we did X, Y, and Z, you could do that. So, I mean, I think large systems with large amount of data and cross conversation outside of just hospitals and in systems will do that. I actually feel like Kaiser might have like a better opportunity to do that. The VA has done a lot of that because they have large platforms of data. But yeah, I think it's coming.
Can you tell people about the Kaiser infrastructure for folks who don't realize why it's the name you use?
Yeah, so mixed feelings about Kaiser. Because it means different things in different places. So I do think Kaiser, at least again, I'm no expert in Kaiser, I'm going to say it or health insurance in general. But Kaiser in California has actual Kaiser hospitals, full hospitals where people can get care. And I think that's like the traditional model. So essentially, if you're insured by Kaiser, they have all your information in one place. You go to Kaiser pharmacies, you go to Kaiser hospitals.
Here and other places where Kaiser has replicated, like for instance, at Children's, we have a Kaiser medical service, it's still within the same hospital. It's actually, I feel it's more of a problem here, like they have to go to a Kaiser pharmacy when it may be not the easiest pharmacy for the family to go to. So I don't think it's, the model is the same, and it's also like in terms of controlling costs, it's not the same because their services at different hospitals. But in places like California where they control the patient from the beginning to the end in all services, we have all the information at their fingertips in terms of if we do X, we can prevent Y, and they reap the savings, right? So I feel like that's the other benefit of it, as opposed to kind of multiple systems involved. And I think that accountable care organization is like kind of one model in terms of how you want to do it, but I think it's implementation. So it depends on how it's actually finally implemented, but even the ACO, like theoretically, would work like that, could fail if it's not implemented the right way in terms of it's actually saying that the people who are actually putting the prevention into place have to benefit from that prevention. And that's not always the case.
And even ACOs, a lot of them have said this is too hard.
Yes, no, and it is hard.
I think I saw him. Yep.
Yeah, building off of his question, and mostly from Mr. Cass, but all of you, have you considered applying that same kind of rationale for the Medicaid program and finance, a non-healthcare specific intervention to violence prevention in neighborhoods with a lot of violence? Because you could theoretically have to calculate the burden of violence in the neighborhood and the proportion that will be reduced by a community program, like hospital-based violence prevention program or some other thing, to then finance that and further improve health.
I know that's heavy.
The National Center for Medical Legal Partnership has been supporting efforts across the country to integrate medical legal partnerships into community violence intervention programs, including those that are hospital-based, and bringing and actually bringing a bunch of those services to the emergency rooms. For example, when people come in with gunshot wounds and things like that, that there's a whole like system wrapped around them that now includes legal advocacy as well in partnership with healthcare.
That's
There's
kind
one
of,
at MedStar.
yeah, and we have one too now. Children's National has a hospital violence intervention program. And that's kind of the other kind of interest that I have. And we are trying to do that a little bit in terms of right now it's a small program, grant funded and government, like health department funded. But once we can expand it, right now it only essentially tries to prevent second injury, third injury, not the first injury. So I think there's a lot of improvement needed, and I think that's where maybe the cost savings would be more significant if you can go further upstream in terms of showing this child. I mean, I can tell you like what patterns I see, but police involved youth end up like I'll see that like when I'm looking at a chart of someone who came in for a gunshot injury, and I open it up and I see police clearance, head injury, cut, and I was like, of course, and you can essentially predict which kids are going to come back and who are high risk for gunshot injury. And so if we can go further upstream in terms of saying, these are our at-risk children, let's keep them from getting shot, then I think there's a chance. But I think that after that first gunshot injury, it's hard. It's much harder to prevent that.
I hate to cut us off, but I do. That's been my job today. So I am just gonna hop up really quick. If you last word, thank you so much to our second panel.
Yeah, for folks who haven't met me, my name is Devin. I like she, her pronouns. I am the editor-in-chief of the Health Law and Policy Brief, and I've been the one making funny faces at the panelists all night. So nice to meet you, Professor Decker and Professor Owen. So Professor Shelton and I would just like to say a few words before we send you off. First, I want to give a huge thank you and congratulations to our symposium director, Hallie Hoffman. A front row seat to the amount of time, energy, and attention that she has put into facilitating this conversation today. So thank you so much for doing that. I think she did a fantastic job. So
yes.
Huge. Second, about a year ago, I attended another event that was hosted by UW and WCL on health equity, health policy, and it was about the Dobbs decision. And one of the panelists on one of the panels emphasized this idea of thinking creatively as lawyers, if we are interested in using the law and policy to create systemic change. she noted that that might not be so easy or come as naturally to lawyers, but I think that's why it's so important to have these conversations across, with folks across discipline, backgrounds, professions, communities, et cetera, and folks who are motivated to think outside the box when it comes to improving health outcomes across the United States. So I've been really inspired by that idea over the last year or so. It's something I've been thinking about a lot, and that's why I feel so immensely privileged to be in a room with folks who are not only willing to have that discussion, but to challenge those ideas that are generated here and take them a step further. So thank you so much to our wonderful, insightful panelists for giving us really powerful food for thought, to the Health Law and Policy Brief, to all of you, to Professor Shelzo Mannion and Health Law and Policy Program for supporting us. I hope you enjoyed this afternoon. So I'll hand it off to Professor Shelzo for some brief words.
I know, but.
This is the final. Again, a deep thank you to everyone here, the students who inspire us with the leadership, especially Callie.
Nice job.
Tremendous work you've done over the last few months. I mean, truly, it's been a few months of work to bring this together. Devin, of course, we want to make sure you were also included in that. Thanks. Our faculty who have moderated the session, these panelists, your expertise, not only have we learned, you've inspired us. So thank you for that, and thank you for the work you're doing. And finally, I want to say to the students, we invite you at the Health Law and Policy Program to get involved, to step up to leadership as these students have done. I know many of you have helped with this project as well. But we invite you to continue these conversations. We were able to do so much, but also so little in the little time we had with these 2 hours. So just think of it as an invitation, an open door to learn more, to engage with any of us, and just think about how you want to help some of this work intersect in your careers. We're so proud of all that you are doing as students and as future change makers in leaders. So thank you all for participating today. And again, come see us, spend some more time with us together. And thank you again to our great panelists. Have a great rest of your day.